everyone. My name is Dominic Angelillo, and I'm a professor of medicine and medical director of cardiovascular research at the University of Florida College of Medicine in Jacksonville, Florida. It is my pleasure to present to you today this topic, which is very current, which is on antithrombotics in patients with CAD and PAD. And I will be showing to you the latest data and clinical implications in providing you with a practical approach towards this topic. These are my disclosures. I will start off with a case presentation. You're seeing a 62-year-old white female in your outpatient clinic, and the patient recently relocated to Bogota after living most of her life in Florida. She brings her medical records from her last hospitalization, and her past medical history can be summarized as follows. She has multiple cardiovascular risk factors, including diabetes, hypertension. She's a smoker, but she stopped, and she has impaired kidney function. She reports having a stent placed in her left lower extremity 5 years ago due to claudication. Her symptoms have improved, but not completely subsided. She reports having a TIA 3 years ago, and ever since this event, she has been more compliant with her medications as she realized that she could have had a real stroke. Approximately 1 year ago, she experienced a non-STEMI and underwent PCI of the mid-RCA. She has a new generation drug-eluting stent. She also has on her angiogram an intermediate 50 to 60% stenosis in the mid-LAD with a negative FFR. And she's been compliant on dual antiplatelet therapy with aspirin plus ticagrelor, in addition to high-dose statin, amlodipine, lisinopril, and metformin. Since her non-STEMI, she has been mostly asymptomatic for angina. She complains of occasional atypical chest pain. She also has occasional fatigue and shortness of breath. Her EF at discharge was 45 to 50%, but was found to be 50 to 55% at a follow-up exam. She also underwent a stress test, which was also negative for signs and symptoms of ischemia. Now, this is a patient who has followed up regularly with a cardiologist in Florida who strongly recommended that she establish herself with a new cardiologist once she arrived in Bogota. And it was important that she be seen at 1 year as decisions needed to be made with regards to her blood thinning medications. Her labs are substantially within normal limits, and as mentioned before, she also has chronic kidney disease. So this is a patient who's in your office, and we need to make the decision on which antithrombotic regimen do you choose. Do you stop ticagrelor and maintain aspirin monotherapy? Or do you maintain dual antithrombotic therapy? And if so, which? Now, when we look at the practice guidelines, this is a patient with an acute coronary syndrome. And as you can see, patients need to be on dual antiplatelet therapy with aspirin and a P2Y12 inhibitor for at least 12 months. The question becomes, in whom and why should we be prolonging therapy? Now, this becomes a very confusing topic because as I will be showing to you some new and emerging data in my presentation, we also know that for the past several years, there have been a number of trials showing that short durations of dual antiplatelet therapy may be enough to prevent stent thrombosis when using new generation drug-eluting stents. And that is absolutely correct. So you may ask why and in whom do we prolong dual antithrombotic therapy? I think it's important that we stop and think, what is it that we are treating? Are we treating the stent or are we treating the patient? And I'll be showing to you in my next slides that clearly we're dealing with the patient. So one thing that we need to keep in mind always is that atherosclerotic disease is a systemic disease. So although we can be very good at putting in a stent and obtaining a good angiographic result, we need to keep in mind that the entire arterial vasculature is exposed to atherosclerotic complications. And Many patients with CAD also have another concomitant territory that can be involved. More or less 1/3 of patients with coronary disease may have another vascular territory. Now, is this important? The answer is yes, because we know that more vascular territories that are involved, this is a concept that we define as polyvascular disease, is associated with worse prognosis. Now, a lot of this data that we are presenting now derives from the REACH registry. What we do know is that patients within their first year of an acute event are at highest risk of having another major cardiovascular event. But you can see even those patients who had a remote event, for example, more than a year ago, still remain at very high risk. We have many registries to this extent. Another very useful registry is this Apollo registry. And this resembles a lot our patient, because this is a patient who had a non-STEMI 1 year ago, who has been symptom-free for the year. She's been on guideline-recommended therapy. And the question comes to your office and asks, doctor, what is my risk of having another major cardiovascular event? And as you can see from all the different countries, this risk is around 18 to 20% over the next 3 years. So it's not subtle. So one thing to keep in mind is that the risk of having another cardiovascular event never goes away. This is the reason why the new European guidelines have introduced a new concept, a new terminology, which is called CCS, chronic coronary syndrome. Why do we call it chronic? Because it persists over time, and there's a clustering of signs and symptoms, therefore syndrome. Now, what you can see from this slide, the Kaplan-Meier curves never plateau. They continue to increase over time. You can have an increased risk in patients who have recurrent events, and therefore high risk of also dying in patients who have uncontrolled risk factors. And on the other hand, patients with a lower risk in those patients who have a better control of their risk factors. Now, why is it important to reduce this risk of ischemic recurrences in a patient with chronic coronary syndrome, or CCS? Well, it's very simple. We know that these patients have lower survival, and this has been shown by many, many studies, as in this one. So let's take a look at what the most recent guidelines from the ESC say with regards to the treatment of patients with chronic coronary syndrome. This is extremely, extremely important. I would also like to emphasize that these same identical guidelines were replicated in the most recent non-ST elevation acute coronary syndrome guidelines released by the ESC just a few weeks ago. So the guidelines indicate with a class 2A level of evidence A recommendation to continue a second antithrombotic agent in addition to aspirin for long-term secondary prevention in patients at high risk of ischemic events and low risk of bleeding. With a class 2B level of evidence A in those patients with moderate increased risk of ischemic events and without high risk of bleeding. So these are very, very, very strong recommendations. Again, a class 2AA. What does that mean? That means that it is reasonable to apply this in your clinical practice. So let's review how we do this from a practical standpoint. The first question that we should always ask, is the patient at high risk for bleeding? Because we don't want to prolong antithrombotic therapy if a patient is at high risk for bleeding. So here you see the multiple risk factors that are out there for bleeding, and they just make common sense. We now have calculators to define the risk of bleeding, such as the ARC-HBR, although this is for the first year. But I think that a lot of these criteria can be considered for patients on the long-term risk of bleeding complications. And why is preventing bleeding important? Well, because we know that bleeding is a risk factor for mortality. So what are the mechanisms that link bleeding with mortality? Well, bleeding can be fatal. It can lead to a volume depletion. It can lead to complications. It could lead to discontinuation of life-saving medications, not just the antiplatelets, but also others such as statins. It could lead to blood transfusions, and blood transfusions aren't good. And simply, we know that there are a number of unmeasured confounders, and sick people bleed and sick people die. So always, in a patient that we are evaluating, we need to rule out the presence of high bleeding risk, or HBR. And if we do have a patient with HBR, it's very simple. We stop ticagrelor and for the most part continue aspirin monotherapy. Now, let's take our patient. It's a patient without high bleeding risk criteria and clearly a high ischemic risk, okay, because the patient has diffuse multivessel disease, the patient has diabetes, the patient has PAD, the patient has renal dysfunction, so many, many factors. Now, moderate ischemic risk is when there's only one of these, but our patient has several. So the question becomes, what do the guidelines say? And as I mentioned before, class 2A, level of evidence A, to maintain dual antithrombotic therapy. So the question becomes, which agent? Now you see the guidelines provide these as options. You can continue clopidogrel, you can consider prasugrel, you can consider rivaroxaban at the vascular dose, and I'll be speaking about this, and you can continue ticagrelor at the modified 60 milligram BID dosing. Now, unfortunately, the guidelines simply provide us with the options. They do not tell us what to do. That's why it's very, very important for us to know the data from the different clinical trials and know the level of evidence and be able to apply this in the best way to the individual patient. So let's start off with options. Is this a good option in this patient? I right here, probably not. Now, if on one hand, we do treat a lot of our patients with clopidogrel because it's a generic drug, easy access, we have some data coming from the DAP trial. Keep in mind, however, that this derived from a subgroup analysis of the trial, and we know that patients with diabetes and CKD generally have more resistance to clopidogrel. So my personal opinion, it's not a good option. But for educational purposes, I would like to show you with all the data. Here you can see the data from the DAP trial. If you continue dual antiplatelet therapy, you have versus those who stop, you have an increase in events in those who stop, and even in the patients who continued dual antiplatelet therapy, mostly clopidogrel, after 18 months, those who stopped, also an increase in ischemic events. So there is value to prolonging dual antiplatelet therapy. The patients who benefited most from this strategy are those patients who had an acute coronary syndrome. As you can see, there was a positive interaction. However, as I also mentioned, patients with diabetes have less favorable effects to clopidogrel because they metabolize the drug a lot less. So again, clopidogrel is out there. Many physicians feel very comfortable with the drug, but there's simply just not a lot of data to support this. You can say, is prasugrel an option? Well, the guidelines do provide that as an option, but I would also like to highlight there's extremely very, very, very limited data on long-term use of prasugrel, and it comes from a small subgroup analysis of the DAPT trial. Well, what about ticagrelor? I write possibly, but this is not the best evidence. And the reason for this, although ticagrelor was specifically studied in the post-MI setting, keep in mind that patients with a prior cerebrovascular event, just as the patient that we are considering, were excluded from the trial, okay? So it's important to keep in mind. Now, we have very nice data, and again, out of sake of academic teaching, I would like to share with you this data. But again, keep in mind that this is not the best option for our patient. Now, here you see the data from the Pegasus study where patients with a prior MI within 1 to 3 years and additional risk factors, you can see that both the 90 and the 60 milligram reduced ischemic events compared to placebo. I think, however, this is a very nice curve because it shows what I had illustrated in a prior slide, where there's a continuous risk. It never plateaus. You can modify the risk by adding a second agent. What is that risk? I would say in clinical trials, it's around 3% per year. In real world clinical practice, it's around 5–6% per year, okay? And we see this over and over again. Now, one thing, however, to keep in mind within the Pegasus study, that the benefit was only restricted to those patients who essentially had not discontinued dual antiplatelet therapy. And you can see that this is a very, very different finding from the COMPASS trial, which looked at low-dose rivaroxaban, where most patients had already been off their dual antiplatelet therapy. And you can see here for patients who have been off dual antiplatelet therapy, there's essentially no benefit of adding ticagrelor 60 milligram. Now, why the 60 milligram? Because it was shown to have a more favorable safety profile in the trial, but it's important to keep in mind that there was, as one would expect, more major minor bleeding, but there were no differences in what we call the irreversible bleeds, the fatal bleeds, or the intracranial hemorrhage. Now, another important trial that was released recently is the TEMIS trial, looking at patients without a prior acute vascular event. And you can see here, these were patients all with diabetes, no prior MI, no prior stroke, where there was a benefit, it was marginal, associated with ticagrelor on top of aspirin compared to aspirin alone. However, what was shown in this study is that there was a very high risk of bleeding, including intracranial hemorrhage. I think that's also very important to keep in mind because, as we will be seeing in the next slides, when we speak about the COMPASS trial, patients without prior MI were also included. So this leads us to the last option, last but not least, which is that of a DPI strategy, or dual pathway inhibition, with aspirin and rivaroxaban 2.5 milligram. And here I say the answer is yes. Why? This is a patient which resembles very much a patient from the COMPASS trial. So I'm going to provide you now with an overview on the rationale for using this strategy. So we're speaking about a new concept. It's called dual pathway inhibition, DPI, which we need to distinguish from DAPT, which is dual antiplatelet therapy. The reason why this concept of DPI emerged is because we know that the vast majority of patients with stable atherosclerotic disease, either CAD or PAD, are on aspirin therapy, and they do experience ischemic recurrences. And we know that many studies of adding a second antiplatelet have not reached therapeutic success. So the question becomes, can a very low dose of rivaroxaban, also known as vascular protection dose, in addition to aspirin, or DPI, reduce ischemic events and maybe even mortality? This is the concept of DPI. We have aspirin, which blocks the COX-1 enzyme, and then we have an anti-10, which is rivaroxaban, which modulates thrombin. Thrombin has an impact on coagulation, but also an indirect effect on platelets. And what we do know that there is synergism between the two pathways. What does synergism mean? It means that the effect on thrombosis, or the anti-thrombotic effect, is better than just each individual agent, even if you were to add the agents, because they enhance their effect. A very simple way of stating this is 1 plus 1 is not 2, but 1 plus 1 is 3. Synergism. Here you see the design of the COMPASS trial. It was a trial conducted in nearly 25,000 patients, patients with CAD and PAD. These were all stable patients. And they were randomized into one of 3 arms: aspirin monotherapy, rivaroxaban monotherapy, but 5 milligrams twice daily, and dual pathway inhibition with a low dose of rivaroxaban, 2.5 milligrams BID plus aspirin. Here you see the primary endpoint of the study. The DPI group of rivaroxaban plus aspirin was associated with a 24% relative risk reduction in ischemic events versus aspirin alone. Although there was a reduction in events with the rivaroxaban alone, this did not reach statistical significance. You see here the outcomes of the study: a significant reduction in cardiovascular death, a significant reduction in stroke, and a trend towards reduction in MI. This is a very important finding because the trial was interrupted prematurely due to overwhelming benefit. I've been doing clinical trials for many, many years, and it's very, very rare that a trial gets interrupted prematurely for overwhelming benefit. Many times they get interrupted for harm. Many times they get interrupted for futility. Okay. Now, getting interrupted for overwhelming benefit typically means one thing: reduction in mortality. And this is what was shown in the COMPASS trial. When we look at the outcomes, these were consistent whether a patient presented with CAD or PAD. You can see the point estimates were the same, 0.74 and 0.72. This was actually the only study that showed a significant reduction in ischemic events in patients with PAD. And in addition, when you look at the limb-specific events, what we call MALE, or major adverse limb event, or major amputation, these were also significantly reduced. Nearly a 50% reduction in major adverse limb events, which included severe limb ischemia leading to an intervention or major amputation, and a 70% relative risk reduction in major amputation. Very, very important. First time that any additional antithrombotic succeeded to this extent. Now, there was another study that further corroborated the benefits of the COMPASS regimen, which was the Voyager trial, and corroborated these results in patients with PAD undergoing revascularization. And you can see here from this analysis that at 3 years, there was an absolute 2.6% reduction on major vascular and cardiac ischemic events. This benefit was shown early as 6 months, at 1 year, and at 3 years. So the curves separate early and continue to separate over time after a peripheral vascular intervention. So very, very important findings. Now, was there a price to pay? The answer is yes. We are dealing with an anti-thrombotic agent, and so it is normal that in the trial there would be more bleeding. Okay, as you can see here, there were no differences in the fatal or fatal bleedings or non-fatal intracranial hemorrhage, where the event rates were extremely, extremely low. So when you take the good and the bad, so the ischemic benefit and the harm, a metric called as net clinical benefit, you can see that there was a strong benefit still in favor of the dual pathway inhibition. Now, There have been a lot of questions in understanding the bleeding profile in patients enrolled in the COMPASS trial. And this is pretty intuitive, right? We're dealing with a new drug in a new context. So who were the patients that were bleeding? Well, there are much of models that have been formulated to identify these patients. That's the reason why I agree with the guidelines on first identifying patients at high bleeding risk. And these are the standard patients, right? You're very frail patients, you're very old patients, patients with anemia, patients with cancer, patients who have a history of bleeding in general. But when we identify the ideal patient, you can see that most of the bleeding actually occurs early and remains stable over time. Well, you can see that the ischemic benefit accrues over time. So you can see that over time, the risk-benefit profile is further enhanced towards benefit. So it's something that we've called in our field of antithrombotics in general, almost as a bleeding stress test. So if you're going to bleed, you're typically going to bleed early. And so in the trial, that's what happened. And so obviously, if a patient's going to have a bleed, they're not going to continue on more aggressive antithrombotic therapy. And so this is the reason why the bleeding risk stabilizes over time. But your ischemic benefit continues to accrue over time. And why? It's very simple. If you remember the Kaplan-Meier curves of ischemic recurrences or residual risk, this continues over time. We have in real world clinical practice a 5 to 6% annual risk. And you can see here in this slide how there is an accrued benefit by maintaining low dose rivaroxaban 2.5 milligram BID on top of aspirin. Another question becomes, how does this strategy of DPI compare with other strategies? Well, when we look at MACE, when you compare with clopidogrel from the Capri trial, clopidogrel plus aspirin, Charisma, and the 2 ticagrelor doses from the Pegasus study, you can see that the reduction in MACE was actually highest in patients in the COMPASS trial. When we speak about MACE, it's death, MI, or stroke. When we look at death, clearly the COMPASS trial was one associated with the greatest reduction in mortality. When we look at stroke, very, very interesting data, the strongest reduction in stroke. And this makes sense, right? Because you have an antiplatelet with a low dose of an anticoagulant, which could have an impact, obviously, on thromboembolic complications. Now, it's not the degree of effect that you expect, for example, in a patient with atrial fibrillation on the full dose of rivaroxaban. This is not what we're dealing with. We're speaking about a patient without an indication to be on an oral anticoagulant. And there was a reduction in myocardial infarction, which was very consistent with the other studies. Was there an increase in bleeding? Yes, as expected, but you can see that the magnitude of increase in bleeding was actually lower than the other studies of prolonged dual antiplatelet therapy. And you can see that the more concerning bleeds, such as intracranial hemorrhage, was also lower than that in patients with dual antiplatelet therapy. So very, very convincing data. Based on this data, the most drug regulating authorities across the world have led to approval of the dual pathway inhibition strategy with the vascular dose of rivaroxaban of 2.5 milligram BID on top of aspirin. Now, there have been many, many analyses deriving from the COMPASS trial. What we have learned is that the benefit of this strategy was consistent across all different subgroups. whether the patient had diabetes, whether the patient had PAD, whether the patient had heart failure, whether the patient had renal impairment. But what we also learned is that many of these patients, such as our patient, have multiple risk factors. And this is what we see in our clinical practice. Many patients have diabetes. If they have diabetes, they may have renal impairment. If they have these two factors, they may also have polyvascular disease. And as you can see, that higher your baseline risk, greater the absolute risk reduction associated with the DPI strategy. And therefore, you're preventing many more events per patients treated. So again, higher the risk, greater the benefit. So what we want to do is we want to exclude those patients at high bleeding risk, identify those patients at higher long-term risk, and these have been nicely outlined by the European Society of Cardiology, greater the benefit of a dual pathway inhibition strategy. Now, I will finalize my presentation with this slide taken from a recent review that we published, which provides an algorithm for the choice of antithrombotic therapy in your patient with chronic coronary syndrome. So our starting point could either be a patient who had a myocardial infarction and is completing their 1 year of dual antiplatelet therapy, just like our patient. Or you can have a patient in your clinic who has chronic coronary syndrome and they are simply on single antiplatelet therapy. They may have had an event 3, 4, 5, 6, 7 years ago. Remember, in the COMPASS trial, the median time for the last MI was around 7 years ago, and these patients were traditionally on aspirin alone. So the first question we need to ask, does the patient have criteria for HBR, or high bleeding risk? And you can see here all the different factors associated with high bleeding risk. So a history of spontaneous major bleed, anemia, thrombocytopenia, severe liver disease, cancer, extreme old age, frailty, or an indication to be on oral anticoagulants. Now, if the answer is yes, the patient is high bleeding risk, as we mentioned before, you want to continue single antiplatelet therapy. And most commonly, this is aspirin, right? This is what we do in our clinical practice. There's some studies that people are showing to use clopidogrel over aspirin monotherapy, but for the most part, it is aspirin monotherapy. So the next question we ask, if the patient does not have high bleeding risk, does the patient have high ischemic risk? How do we define that? Well, does the patient have peripheral vascular disease? Does the patient have multivessel coronary disease? Does the patient have additional enrichment factors, such as chronic heart failure, chronic kidney disease, diabetes, recurrent MI? Now, if the answer is no, well, that patient's not high risk. And you would also continue single antiplatelet therapy, again, most commonly aspirin. But if the answer is yes, a key question that we need to ask, did the patient have a prior cerebral vascular event? If the answer is yes, the only strategy that has been tested has been the DPI strategy, okay? So low dose aspirin plus vascular dose of rivaroxaban. Very, very important. Now, if the patient is at high ischemic risk but did not have a prior ischemic stroke, well, we need to ask the question, did the patient have a prior MI? The answer is yes. Well, we do have two strategies. We have the strategy of prolonging DAPT or considering DPI. If we consider prolonging DAPT, my opinion, the best evidence is with the ticagrelor 60 milligram, because we have data from the Pegasus trial. Alternatively, you can consider a DPI strategy. Now, if the patient is remote from the MI, the only strategy we have is DPI. If you have a patient with chronic coronary syndrome, but without prior MI, as shown in the COMPASS trial, also there, the strategy of choice is DPI. So here you have an algorithm. We now have guidelines. We have guidelines from the European Society of Cardiology in 2019 on chronic coronary syndrome, which now provide a class 2A recommendation for prolonging dual antithrombotic therapy, integrating in the guidelines now a new strategy, which is DPI. We have just a recently reported data from the European Society of Cardiology and the guidelines on non-estivation acute coronary syndrome, which provide the same level of recommendation. Here again, we're speaking about patients with chronic coronary syndrome. We also have guidelines from our vascular societies, specific for patients with peripheral vascular disease, where a DPI has been the only strategy shown to be beneficial. So having said this, you now have available the tools for an adequate decision-making in your patients coming into your clinic, whether they have chronic coronary syndrome, whether they are post-MI, whether patients with PAD, to help guide you on the best treatment strategies when it comes to antithrombotic therapies. I want to thank you very much for your attention. I'm sorry that I'm not able to be there in person with you, but at this point, I'm happy to entertain any questions. Thank you again for your attention.